Dear colleagues, it's a pleasure for me as a director of the PAHO Collaborating Center to talk to you about Sherbrooke Faculty of Medicine and Health Sciences educational journey with primary health care. The Dean of our school, Dr. Pierre Cossette, wish you a good dialogue on this issue of primary health care, and he is engaged to support us and all of us in that journey. Um, I'll say a few words in Spanish. Say buenos días, queridos colegas. Es un gusto de presentar la experiencia de la Facultad de Medicina de Sherbrooke con la atención primaria de la salud. Deseo con y no, deseo con y no towards, porque nuestra Facultad de Medicina tiene una larga historia de compromiso with atención primaria de la salud. Hablo español un poco solamente. Así pues, voy a hacer esta presentación en inglés. Donc, as I said in Spanish, I use the term with instead of towards, since our school has a long history of commitment and engagement towards primary health care. And in fact, its history is significantly linked with the development of primary health care. I think that citation from my philosopher Platon is important for our discussion today. The direction in which education starts a man determines its future mind. This is a major thought that we should keep in mind when we talk about primary health care, education towards primary health care, and how to improve the adoption of primary health care by our medical students and our future graduates. This is Sherbrooke Faculty of Medicine, located in Sherbrooke. Sherbrooke is in the province of Quebec, which is a province of Canada, an eastern province of Canada. Canada is a 33 million people country, while Quebec has 7,500,000 people. Sherbrooke is a mid-sized city of about 150,000 people, and it is located 100 miles east of Montreal, or 160 kilometers. Sherbrooke Faculty of Medicine is one of the 4 Faculty of Medicine in Quebec, the other one being University of Montreal, Université Laval at Quebec, and University McGill. Our history is linked with primary health care. In fact, our faculty has been founded in the 60s with a specific objective to respond to the needs of communities out of large cities. Commitment towards primary health care was present at the beginning and has still been there for the following decades. Sherbrooke Faculty of Medicine is recognized for its educational innovation, and in 2001, it was designated by the World Health Organization and the Pan American Health Organization as a collaborating center on the development of health human resources. In 2006, it became the Faculty of Medicine and Health Sciences in order to recognize our involvement in the training of other health professionals, mainly nurses, physiotherapists, ergotherapists, pharmacology, addiction therapists, and others. Our faculty actually has approximately 525 full-time teachers. Out of them, 185 are researchers, and out of them, 65 are clinician researchers, and the other teachers are clinicians, mostly MDs. We have approximately 1,200 part-time teachers, 3,500 students, and 1,000 of employees. Commitment with primary health care. As I told you, we were founded really to respond to the primary health care needs of our province, to develop physicians who will be trained with interest in primary health care in what we call generalist specialties, and who will be interested to work out of large cities. Our mission considers social responsibility for the last 15 years or 20 years. And even though social responsibility was not as an official term in our mission prior to that, the idea of social responsibility has always been there. Our expected results regarding graduates actually are that 50% of them will go in family medicine, and another 25% will go in generalist specialties linked to primary health care. Just want to say a few words about the family medicine program, which is a leader in Quebec and in Canada. And it is training residents for more than 40 years and mainly in regional areas. And finally, we have internal collaboration regarding primary health care. I think it's important to look at how physicians are trained in Quebec, in Canada, and mainly to compare it with South America. Okay. Students come either from the college or from university training in science or in health sciences. After their admission, they complete an MD program, which is usually 4 years. One program in Montreal is a 5-year program, but usually it's 4 years. After the MD program, students have two choices. They go either in family medicine for a 2-year residency program, which is the norm in Canada, with some of them doing an optional 3rd year, or they go in specialties for a 5 to 7-year program, while some of them will also do an optional fellowship. And then they go and practice. I think it's important that to discuss with you about the importance of partnership when we talk about the development of health human resource, mainly when we talk about primary health care. And in fact, in Quebec, we work with close partners on that objective. Faculties of medicine, government, healthcare institutions, associations of physicians, residents, students, public, and so on, meet all together at different tables and committees in order to consider the population needs and make decisions regarding the number of admission of medical students in faculties of medicine in Quebec, the distribution of residency positions among the different specialties, and the location of practice in the different health areas. Let me talk to you about the MD program shortly. The MD program received its first students in 1966. It was an integrated system-based program at that time. It was geared toward, as I said, training physicians will have a global approach to healthcare and who would be interested to practice in out of large cities areas. In 1987, we did a major reform of our program, and we changed our teaching approach, which was mainly lecture-based, with a problem-based learning approach, and also with many actions in order to better orient our educations toward the community. For the last 12 years, we had a significant increase in number of students in order to respond to the needs of physicians in Quebec. And in fact, we more than doubled our number of first-year medical students. In 2006, we opened 2 outside campuses to offer the whole program in order to respond to that needs. And we also make a reform of our clerkship with a larger emphasis on the CanMed's role and also with a practice task-based educational approach. And finally, we are actually in some reflection about a curriculum renewal for the next few years. Just to show you that slide, to confirm that approximately more than 75% of our teaching activities are in small group of approximately 8 to 10 students with a tutor, teachers, and that is the approach that is used for the teaching of the theory of medicine, the practice of medicine, communication skill, professionalism, and so on. This slide just shows you about our 2 other campuses that we opened recently in 2006. The first one that you're at the left on the slide is Saguenay, which is approximately 500 kilometers from Sherbrooke. It's in the northern part of our province with a region which is a little bit isolated. That site received 35 first-year medical students since 2006. The next one is at the right of the slide. It's in Moncton, which is in our neighbor province. New Brunswick is a bilingual province, a smaller province without a medical school. And Sherbrooke has a commitment to train Francophone New Brunswickers for many years. And in 2006, it opened that campus in order to offer the old program, in order to increase the number of these students who will adopt a location in New Brunswick for their practice. The MD program is a 4-year program, as I told you. The first 2 years and a half are preclinical years, and then a clerkship of 18 months. Just to realize that this is an integrated system-based approach, mainly PBL and small group teaching, and that with the teaching, a continuous ongoing teaching of clinical skills as well as professionalism throughout the curriculum. Just want to confirm that during the curriculum, in the first semester, okay, at the end of the first semester, our students spend 2 weeks in clinical immersion, mainly in primary health care clinical sites. Similarly, in second year, they do another 2 years of clinical immersion. Finally, when we look at the clerkship, I think it's important to realize that the clerkship includes 8 weeks of family medicine, 4 weeks of public health, and 20 weeks of general specialties. So general internal medicine, general surgery, general psychiatry, and so on. So that's important to realize that our primary health care is really implicated, in the program, to the old program, and not an add-on once in a while. So, as I told you, and finally, I just want to say that there is a significant leadership by family physicians in the program. And in fact, the program director is actually a family physician. The clerkship director is a family physician. Some unit directors are family physicians. And this has had an important impact. That slide shows our network of clinical sites. And in fact, we have an integrated network of healthcare institutions, primary care, secondary care, tertiary care, urban areas, semi-urban areas, rural areas, and remote areas where we train our students. Sherbrooke is our main center, and we have two other main centers, one in Moncton at the right, one in Saguenay, and one in the south shore of Montreal. In our network, we have one university hospital, which is the one at Sherbrooke, 6 community hospitals within cities less than from 50,000 to 150,000 people, and 10 healthcare institutions or community clinics in smaller cities with less than 5,000 people. The teachers, all the teachers in these hospitals are nominated as teachers at the University of Sherbrooke. All of them are remunerated, and all of them also receive faculty development. Let's go at the results. Let's look at the results. And in fact, that slide shows you succinctly our results in the last 4 or 5 years. In fact, actually, our graduates, approximately 45 to 50% of our graduates choose family medicine. Another 25% choose generalist specialties, while others will choose subspecialties. Interestingly, the percentage of first choice for family medicine is almost 35% in the last 5 years. The international commitment that our school has regarding primary health care merits to be discussed. We, as I told you at the beginning, we are a collaborating center for WHO and PAHO. We are involved in the network TUF. We are involved in the NET, which towards Health Equity Net, and other international institutions with an interest in primary health care. We have significant projects to support primary health care and the development of family medicine, MD program, and residencies. And I just want to talk about 3 of them. One is in Mali, and it's a partnership for more than 15 years with multi-million dollars funding for the project. We have a partnership with Uruguay for the last 6 years in order to support their MD program and the development of family medicine. We have, and that project has been supported also by external agencies. And more recently, we have activities in Haiti, and we are actually trying to improve or increase that group of activities. What are the challenges regarding primary health care? What are we facing? And in fact, just want to summarize what we see, or what I see as challenges. First is apathy or self-satisfaction of what we do. And it's easy for all of us to be self-satisfied about what we do. Second, we have resistance, and we have a lot of resistance in our faculties or with other partners. And sometimes we may say that we have some cowardness regarding actions to be taken. It's sure that we are absorbed in other pursuits, in other objectives, and sometimes it's difficult to put all the time necessary to promote primary health care. There's also what we call the hidden curriculum against primary health care. And in fact, unfortunately, in the population, through the government, through also our colleagues, family physicians or primary care healthcare specialists are seen as doctors of second order and not really real doctors. And finally, as I said, the recognition of primary health care by other stakeholders, by the government, by the healthcare institutions, by the paying agencies also. It's very, really important if we want to attain and develop primary health care as we want to. Let me conclude by that slide saying that doing it is costly. Going for primary health care is costly. It costs money, time, resources, commitment, engagement. Okay. But not doing it will be more costly. More costly for our medical schools, more costly for our government, more costly for our population, which will not receive the kind of care that is needed. Thank you very much for your audience. I hope that that presentation gives you some ideas of our educational journey with primary health care. We have included in the dialogue website a longer presentation of what I said today, and you are invited to look at it. You are also invited to take contact with me and call me or email me in order to discuss about all of these issues. And I'm looking forward to discuss with you about this and also to meeting you in future meetings, in future months and weeks in order for us to expand our understanding of primary health care and the role of education in our faculties of medicine toward primary health care. Thank you very much. Muchas gracias.